Good morning, everybody. Welcome to this webinar this morning. We're just waiting for people to join us. We will kick off. I am Hazel Cheeseman. I'm Deputy Chief Executive of Action on Smoking and Health. It has been a slightly busy morning for us, as some of you will have seen in the news, with the publication of a new independent review into tobacco control policy. I might use Chair's privilege to say a few words about that before we start. But as we've still got people coming in, Robbie, can we set it so that people just come in automatically? There we go. And I think Robbie's going to share some slides for us as well. Oh no, we still have. Robbie, make sure that people can. It's set for people to come in automatically, and then you can share the slides, because otherwise we'll be in all sorts of bother. I'll start then by talking about this independent review, which has been published this morning. So tremendously welcome. I mean, have a look on Twitter, #CalmReview, I think should bring you up lots of the information on this. Just to give people a flavour of what's being recommended. It's so this is a review commissioned by the Secretary of State, and it's about how can the government reach its ambition to be smoke-free by 2030. And what Javed Khan has said is that he wants to see there are 4 things which the government absolutely must do, 4 critical recommendations, and then there are 15 recommendations in total. But the first of those recommendations is an increase in investment in tobacco control of 125 million, and that would be to do a whole range of things, including invest in, supporting more smokers in disadvantaged circumstances to stop smoking. And one of the measures that's specifically recommended in the more detailed review is about investing in a switch to stop type program, offering e-cigarettes to people in disadvantaged circumstances. And that will, I think, form part of our discussion today as well. The other really eye-catching recommendation is around raising the age of sale, but I think we could spend the whole of this webinar, which is to talk about VBA and homelessness, talking about that. Robbie, are we able to share the slides yet? And we'll get going. Fantastic. Can everybody see that? Okay, so this morning we've Louise, you might want to turn your camera off again. Louise, we will be joined by Louise Ross shortly. She's prematurely turned her camera on, and she's going to be introducing our training package. And for those of you who are not familiar with this webinar is jointly with the NCSCT, and they have launched this new training package on delivering VBA in homeless settings. The VBA module has been produced by NCSCT in partnership with OHID, and we're going to hear from OHID as well this morning. And it's now live on the NCSCT website. I'm sure because you're on this webinar, you've probably received the e-bulletin from the NCSCT already. I think it may have already gone out, but if not, I'm sure it will be circulated after this event. And we're going to have some presentations from NCSCT, from OHID, and from an expert by experience, as well as academics from King's and UCL. And we'll have a Q&A at the end. Please put your questions in the chat function, and we'll get through as many as we can during the event. If you've got any issues, then do email the admin at Smoke Free Action inbox, or you can add it in the chat, but it's probably better to add it to that admin inbox. And we're going to be recording this and widely distributing it afterwards. Okay, what's on the next slide, Robbie, or have I just powered through all of what was on my following slide? No, we're on to Louise. There you go. I will turn my camera off and invite Louise Ross from NCSCT to tell us about the module.
Thank you, Hazel, and sorry for doing it too prematurely just now. It was anxiety to get the buttons right. Okay, so hello everybody, and welcome to the webinar. I'm going to talk about how the training package was set up and the things we learned along the way, because I got some amazing insights from people who are already working in the field. But before we go on to that, I'll just say a little bit about myself. Next slide, please, Robbie. Yeah, no, that's I'm not seeing my slides, Robbie.
Robbie, we seem to have switched, you seem to have switched screens, so we can't see the slides anymore. You might have to stop sharing and reshare.
While that's being sorted out, I'll just talk a little bit about how I came to be involved and what my background is on working with people who are experiencing homelessness and smoking. So when I managed the Stop Smoking service, one day a man who was homeless turned up at reception at City Hall with all his bags and his sleeping bags, but he got a vape in his hand as well. And he said, thank you. What am I supposed to do with this? Somebody's given me this. I want to stop smoking. I don't know where to charge it. And the place he was living at wouldn't let him charge it. The healthcare centre that he used wouldn't let him charge it. And in the end, we got him linked in with a vape shop who said, of course you can charge it up there. And that started our interest in helping people who were experiencing homelessness and were smoking to do something about it. We realised it was an incredibly slow process. There was a lot of suspicion about the Stop Smoking service and any kind of health offer, really. Fears that this was a plot to make people more sick. But of course, amongst some, there was some real enthusiasm. People definitely wanted to do something about it. We realised that they were not interested in NRT particularly, but they were very interested in vaping. And that helped me kind of shape how we approach this particular task in terms of setting up a training package for people who work in homelessness settings. I was part of the LSBU advisory group that Sharon Cox led. And the last bullet point here, stopping smoking meant I didn't have to pick up dog ends, was something that really stuck with me. I hadn't thought at the time just how important it is to give people that dignity of not having to pick up other people's discarded cigarette ends. Next slide, please. So as part of preparing for the writing of the VBA training module, I talked to a lot of people who have worked in this setting and are still working there, and some very powerful comments came up which we weren't able to actually include necessarily in the training package, but I didn't want to waste. So I went back through my notes and I've included them here because they were so very powerful. And the first one, ignoring smoking is facilitating dying. And that really, really stuck with me because I know from talking to people in the wider health and social care field that there's a reluctance, a resistance to raise the subject of smoking because they fear that it will alienate people and make people uncomfortable. But this really is a very stark way of looking at it. The fact that it increases health inequalities as well. We talk about the levelling up agenda. We want people to be included in society and have the same enjoyment, so quality of life that the rest of us have. This is smoking as a divisive issue that increases health inequalities. The fact that for some, the smoking could lead to loss of tenancy. If people are just about managing to hold on to a tenancy, their expenditure on smoking it is a risk. It's a threat to their ability to maintain their tenancy. So it becomes very, very important. And insights like this, somebody who thought this was an unfair thing to do, talking to people about stopping smoking, but when he started talking to people about their smoking, he realized that that there is an enthusiasm about quitting, that they don't want to make their health worse, not all of them anyway. And of course the range, that some people may be rough sleepers and not in a position or a mindset to do much about their health generally, but Other people, have fallen on hard times. They might be just starting tenancies. There's no typical profile, and later on we'll look at, where the best wins could be when you're gaining confidence in talking about this. Next slide, please. Now, it's very clear that people working in the social care setting generally feel they've got a lot of key performance indicators, a lot of targets. They will often say, I just haven't got time to take anything else on. But this is about upskilling. So doing this course is about increasing people's skills in helping others improve their health, improve their well-being. So it's very important because it's part of what we should be doing in this field. We can't expect users in homelessness settings just to go to a stop smoking service. It was very clear from everybody I talked to and from my own experience as well that the approach that we might take with the general population of saying, there is a stop smoking service, if you contact them, they will help you, and people will then put it in their diaries and they'll attend their appointments. This is much less likely to happen with people who are experiencing homelessness. They don't keep diaries. So that advice, the knowledge about how to make a switch away from smoked tobacco needs to be embedded in the services that they use, that people actually there on the ground can have these conversations. Some won't want to stop now. They might not ever want to stop, but others may be much more open to the idea. And if somebody's health has got worse, if they're coughing a lot, if they're starting to feel quite poorly, and smoking is likely to be at the root of that, they may get to the point where they actually want to do something about it. So keep raising the subject, and you may get a no 9 times out of 10, but it's that 10th time that makes the difference. Next slide, please. If you're stuck with what to actually say, you can revert to a demonstration. So demonstrating using a vape, using NRT. If that's the only thing that you remember how to do, that's really good, because people want the confidence to actually be able to use something that will help them stop smoking. Better information, that this is something that you can gather along the journey. It doesn't all have to be done at once. You can keep picking up insights about how to help people stop smoking and what makes the difference. Talking to experienced vapers, talking about this to people who've stopped smoking, getting those personal insights can really help other people's attempts be more successful. And as I said before, look at where the wins are. So a single mum might be just ready to stop smoking more than somebody else who's still living a very, very challenging life. So start off where the wins will be, and your confidence will grow. We've got lots of resources on the NCSCT website. Have a look at some of those. The films are brilliant. Everyone that you look at will start to increase your knowledge and raise your confidence levels. Next slide, please. Think about the policies in the homelessness settings. If you've got a residential setting where people can't vape and they can't smoke, they're not going to see the benefits of that switch. But if you have say a common area, or the grounds, the gardens, where they can vape, that will start to make people think, well, I can get my nicotine that way. I don't have to smoke. There are alternatives. Staff smoking is an issue. We know this from mental health hospitals as well, that when staff smoke, especially when they used to smoke with their patients, that just gives a message that it's all right. It's seen as almost a therapeutic intervention, and this is really, really unhelpful because it perpetuates users smoking. So look at the way that smoking is treated as a whole in your organisation, and start to see what will help service users. Talk to them about what they'd like to see as well. And we heard when we were making the film how much they appreciated staff not smoking around them, setting a good example. The health message may be less important than talking about money saved. People may be fatalistic about their own health, but when it comes to saving money, that could be a very motivating factor. And the mental health links, particularly having fewer meds. Sorry, my phone's just going and I'm trying to turn it off. I must have to ignore it. When people can reduce their psychotropic medication, that's really exciting to them. Whether it's somebody who's homeless or somebody who's using mental health services, the idea that they can reduce their psychotropic meds because they've stopped smoking is a very, very motivating factor. Next slide, please. So this paternalistic idea that smoking is the least of their worries, this, we heard a lot, comes from staff, not service users. And I was asked several times to help make it easier to challenge these preconceived ideas, and not to be a barrier to people who actually do want to stop smoking. Talked to a number of people from the Everyone In project or similar in different parts of the country, and what they all said was how very popular vaping is. That once people had got access to a vape and were able to use that instead of a smoked cigarette, their confidence increased, and they were much more positive about it. So instead of something being taken away from them, they had something to substitute for their cigarettes. And people were realistic as well. And this is reflected very much in the training package, that you can't necessarily take people from quit date right through to a 12-week quit. That won't happen with all of them. So that shouldn't be a barrier. It shouldn't be something that disheartens you. But keep people comfortable, show them options, start to get them to the point that they can look after themselves in terms of their not smoking, and make them feel that they can really do it. And I was intrigued by somebody saying in the north of the country that the project that she was working in, once people got a hold of a vape, they were using fewer illegal drugs. They were going to their vape rather than to heroin or to cocaine. And I thought that, okay, there's no evidence for that necessarily, but what an interesting idea that this might actually help people get off certain other drugs. Next slide, please. So if you're still wondering, or if your colleagues are wondering, do we really need this training? Ask this question: are we okay with these early deaths? Because we could be the barrier to reducing the number of early deaths, and we should be the enabler of better health, not a barrier that causes continuing early deaths. And to help users learn self-care and give them something that they think, that's a really good idea, I'm going to try that. That's such a rewarding thing to do. So I'd say complete the training, encourage your colleagues to do it too. We'd love to hear from you and to find out what you thought about this. It's obviously a very innovative thing to do, and we thank OHID for asking us to do this in the first place. NCSCT was very glad of the to be asked to do it. I really enjoyed the process, and I've learned so much about how to help a very challenged group of people. And I hope you can enjoy that too. Tell us what you think of it. And now we're going to actually see the film that we made at the Stairway Project, run by the Dear Albert Project. And one of the service users and worker here is going to come and talk to me later as part of the interview. But Robbie will show the film now. Thank you.
Thanks, Louise. Great presentation.
Being homeless and a smoker, I believe it can be a little bit harder. People don't know that you can get help to give up smoking.
I've been homeless about 2 years now. The whole time I've been homeless has been with my brother. Beats being on your own. I'm hopefully going to get help together as well, so.
and I became very depressed, suicidal, and it was too much for them to handle. So I ended up street homeless in London, which was, as I'm sure you can imagine, horrendous. Yeah.
I was abused when I was a kid. I left home at 16, and I've been homeless for years.
I had a very traumatic childhood. I was around quite a little bit of domestic violence, physical abuse. I ended up sleeping on the streets. That was probably 1997, homeless on and off for the next 20 years.
I came to be homeless about 20 years ago. My ex-partner was abusive, and that was the start of my life on the streets.
As my drinking got heavier, the smoking followed. They kind of went hand in hand. Yeah, like 20 a day, sometimes more. It's something social to do, and it passes the time, especially if it's like cold, miserable. So unfortunately, there are positives when you're homeless, yeah.
If you are homeless, it's not easy. If you are having stress times, it helps.
There's a lot of mental health involved, and obviously the addiction's not helping that, it's making it worse, but that's their way of coping. I think about 90% of the service users smoke one thing or another.
Being on the street isn't a good way of living anyway, and being a smoker on the street, it doesn't help.
Got a bad chest quite a lot of the time from it. Yeah.
You know, you can just hear them barking, proper coughing, and yeah, a lot of lung problems.
The smoking was really making me ill. Chest infections and wheezing and breathing problems, and I could hardly walk because I was always out of breath.
I can't run for no longer than 2 minutes without getting out of breath. I started smoking when I was 10 with my friends.
I started smoking when I was about 9 years old.
I started when I was 8-year-old.
About 7 years old, I used to smoke because it was a social thing, and it took away the hunger pangs, and everybody smoked.
I just abused my dad's folks. My mum used to get blamed for it. It was me.
You tend not to have as many cigarettes being homeless because you're not as well off. So a lot of homeless people will smoke off-cuts of cigarettes, dog ends, smoke out people's ashtrays off the floor.
They don't know what's in it, they don't know what's been mixed in with it.
There's all kinds of bloodborne viruses out there. You know, there's the COVID situation going on. It's not safe not to have your own cigarettes today. And also, like, with the substance abuse going on, i.e. spice, mamba, and you don't know what you're picking up and what you're smoking.
We've got to try and do something to get them off the cigarettes, but it's easier said than done sometimes. They can always catch a fag off somebody. Oh, giz a drag.
Vaping is a good method of reducing the tobacco and eventually stopping.
I've spoken to a few of the service users where I work, and they're all interested in it.
Well, I've got a baby on the way, so I decided to get a vape. Just give it a go. Try buying one of them throwaway vapes. Just see how you feel. It's also cheaper in the long run. They last a lot longer.
The only message I would give to homeless staff, talk to everybody how you would want to be spoken to yourself, and be as nice as you can.
Continue to be non-judgmental about people's habits, whatever they might be, but also don't assume that they don't want to quit.
If service providers want service users to give up smoking, maybe they could show willing by showing that they vape or that they don't smoke. It would be a good start.
If there was a stop smoking nurse, they shouldn't really be stood there smoking with us and then afterwards telling us to stop smoking and do this and do that when they've just had a fag with us.
The message I'd like to give to other homeless people who are still smoking would be, if you can quit smoking, it will be one less thing to worry about. And if you're using other substances as well, and you need to find food and a shower, if you can crack it, it's one less thing to think about.
But don't try to do it alone. Get help. It's hard to admit we are addicted, but there are plenty of people who can help you.
Yeah, I would definitely try to encourage them to quit smoking.
If a homeless person could quit smoking, it might give them the drive that they need to think, actually, I've not smoked today, I wonder what else I can put my mind to. Finding supported housing or hopefully work. Yeah. It's a positive message, I think. Yeah.
Start vaping, keep that going, cut that down and give up everything.
Doctor said to me, you could be dead with a month. As soon as he said that, I quit. End of June, I'm 3 years clean. I'm here to tell the tale. A non-smoker. And I'm loving it.
Well, I'm sure that we will all agree that was a really powerful video, and it's part of the it's at the beginning of the NCSCT online module, which will be sent out after this event. And I'm sure that many of you found that very powerful, and I'm sure there are colleagues that we would all want to share that with. I'm going to invite Michelle now to join us to speak, and we're going to be coming back to Louise later to talk to one of the experts by experience. So Michelle is Programme Manager at OHID London, and she's going to talk to us about why it was that London wanted to invest in this module. Over to you, Louise. Michelle, sorry.
That's okay, Hazel. It's a bit tough to kind of follow something as powerful as that. So I'm actually not going to take much time up because I was really keen that we saw the kind of film today and that we have enough time for kind of Louise to speak to her by expert by experience. So, but just a little bit of kind of background of how we got here, I suppose. So at the beginning of kind of COVID, so back then, our team was asked to support the programme of Everyone In. And we were kind of tasked with very quickly pulling together a drug and alcohol provision to work in the hostels and the hotels in London. It became very, very evident quickly that a number of individuals were being evicted because of their smoking. So we had the opportunity to work with our provider who was supporting the drug and alcohol elements to kind of look at the smoking issues at a strategic and delivery level. We then had the opportunity a little bit later on as things progressed to bid for some money from what was then MHCLG to kind of really look at kind of how we were having an impact around smoking. And there has been an evaluation done of that work, which I'm sure most of you kind of have seen previously. And I can always put the link in the chat afterwards. And it was really striking, some of the things that came back. And I think the thing that really resonated with us was we hadn't been asked about not smoking, and that kind of then drove kind of a series of local kind of workshops and consultations, and we spoke with partners, particularly kind of the GLA, so the Greater London Authority, who had been supporting the work in the hotels. You know, how could we kind of start to progress this whilst everybody else was really busy with the general work around COVID? So we brought together, as I said, a number of partners, had a number of workshops, and really started to think about, could we kind of fund something in London? At the same time, the local authorities in London and across the country were being identified where the largest amounts of rough sleepers were, and they were being given money to develop local systems specifically around drugs and alcohol and rough sleeping. And for London, we said, actually, some of the things we'd like to do don't really work at a local authority level. So we'd like to look at this regionally. And a number of bids were prepared. Now, I sneaked in one around tobacco. So looking at how we could kind of increase training opportunities for individuals that were working in the drug and alcohol and the homelessness sector. Also kind of looking at how we could kind of work around some incentives. Now, it didn't quite fit with the grant conditions, so unfortunately we weren't successful. But based on the work we'd done, particularly kind of from the feedback from all of the service users, that kind of idea lingered in my inbox. And then as kind of PHE transitioned to OHID, there was a very, very short window where a very small amount of money, and I will say that, a very small amount of money became available to kind of look at very quick projects. At that point, I picked up the phone to Andy, at NCSCT, who was, I'm going to say this, Andy, so I apologise, waiting for a ferry on his holiday, but managed to very quickly kind of turn around a project plan with me. And then Louise kind of arrived very soon after. And I suppose the rest is history, really, kind of through kind of quite kind of humble beginnings and kind of speeding through, kind of we managed to get, with everybody's hard work, to where we are today. I think it's really clear that those that are experiencing some of the worst health inequalities need to know that they can quit, and we need to give people the opportunity to quit, particularly kind of with the use or the increased use of vapes. And I suppose the hope is that the course will give workers enough information to feel confident to start this conversation with all of those people that are around them. But we're under no illusion that really this is only the start of the process, and we have to be mindful of everything else that goes on kind of in our existing services. But we really heard, you know, very, very clearly that, you know, kind of we need to make sure that people are asked. We need to feel confident so we can ask people and we can kind of offer people the opportunities. I think the video is so powerful and it speaks for itself. You know, kind of when you offer people opportunities, people will take it. I think we need to kind of keep working to make sure that if people then need specialist services, those services are the right services for individuals. And as I say, it's really just kind of the start of it. Now, I've managed to canter through that, I think, in about 2 minutes, which hopefully gives an extra 3 minutes back to Louise, kind of as part of the interview. So I'm kind of there, Hazel. Quickly canter through.
Well done. Thanks so much, and I hope you join us for the Q&A, because I think it would be really useful to continue that conversation about, well, this is the start and where do we go next, and hopefully we can do that in the Q&A. So I'm hopeful, if Michelle turns her camera off and Louise can turn her camera back on again, that we will be joined by Louise. I'm going to hand over to you to introduce our guest and to tell us a little bit more about what it means to stop smoking.
Thank you, Hazel. And yes, let me introduce my friend Robin.
Hello.
In fact, Robin, do you want to say something about yourself?
Hi everyone, thanks for having me. My name's Robin, and I'm recently 8 months sober and not homeless anymore, and I volunteer here at Dear Albert. So yeah, happy to be here. Thanks for having me.
Lovely, well, lovely to see you. And so tell me a bit about how long were you homeless for?
So street homeless for about a year, and then a year or two before and after that, sort of sofa surfing and trying everyone's patience, like my family and friends. So yeah, but like roughly in about a year, yeah, in central London mostly, yeah.
And smoking was part of your life then, wasn't it?
Well, absolutely, 100%. I can't lie about that. And I would say, I was very not just suicidally with an ideation, but more like a determination to do it. And so anything that I could find to just calm it down a little bit. Obviously, I never expected for a million years that I would end up on the streets. And so cigarettes became something. To be honest, I had this idea of like, well, I'm not going to be here for that much longer, so I might as well smoke. And so that's what I was doing a lot. I didn't, you know, I wasn't seeking help at the time. I'd totally given up. And actually, whilst people are unlikely to perhaps give you money for obvious reasons, there's always someone that smokes. Yes. So train stations, near an airport, everyone's always got cigarettes, and they feel, I feel, I mean, I was manipulative, but I feel as if perhaps they think they're helping a little bit, and they don't mind because they're a smoker too. So very easy to get, yeah.
And did smoking sort of fulfill a function for you when you were experiencing homelessness?
I suppose it does for a bit, but anyone who smokes now or smoked in the past knows that having one now and then, perhaps after a nice dinner or on holiday, is very different than smoking all the time just for the sake of it. And to me, it became almost like an obsession. I've got nothing else to do. I'm not trying to look for help or / there is no help. So, and I think that's when it becomes dangerous in terms of like picking. I used to pick up anything from a used ashtray. And so not only does that have, you know, it was before COVID. I mean, you know, could have got all sorts from it, but a number of times picking up something or being given something that's definitely not a tobacco cigarette, that's got something else in it, which obviously made me very, well, it sent me off my rocker even more, to be honest, so not good. But certainly, yeah, I think it went from taking the stress out to just, I don't know, it might have even been like a self-punishment thing, like this is all I've ended up as, so really sad, but yeah.
And when I talked to Fleur here, she said that it stopped her being hungry. So when there wasn't money for food.
Yeah, and I think, I mean, when was I born? 85. So when I was at university, it was still very popular and fashionable to smoke. People like Kate Moss and all those supermodels, that was what they lived on. So I think I'd learned that as being a teenage boy or young man. And so, yeah, and it does help because it fills you up with something.
Yeah.
So, yeah.
Yeah. And when you had any kind of health care during this period, did anybody ever mention smoking to you, or how you might want to stop?
No, the only time, and I don't blame them for that. I think if you're dealing with someone who's on the edge, that's the most important thing, is a shower or something to eat. But I would say that I saw it prominent in settings like wards, or perhaps if I was on like I don't know what they call it now, but maybe that's like a section type ordeal where it's perhaps unacceptable for you to leave, or you can't keep pestering the same person to take you out, and you haven't got any cigarettes anyway because they're really expensive. And so in terms of that, it was like a mouth spray or the inhalator. So, but certainly no, sort of no follow up. It was kind of like off you go back into the wild kind of thing. Yeah. So yeah.
Yeah. And you're vaping now, I think you said.
Yeah.
So
thanks.
Tell me how things are going now.
So I'm well. The most important thing to me, because it's immediately life changing or preventing me from dying, is no drinking. So 8 months is great. And so in recovery, a lot of people say one thing at a time. And so I will often quit for 6 weeks with nothing. But thanks to you lovely people, instead of going back to cigarettes, you gave us some jewels, and they're really good. They're inexpensive to buy the refills to, and I think that's important as well. So yeah, I'm doing that.
Good. Are you liking them?
Yeah, really good. I find that things like the spray and the gum and the patches are amazing, but once you're outside of the NHS system in terms of you should be all right now, they're very expensive. So the dual thing is actually quite affordable. And what I started to do is I can't give money out to people anymore on the streets because I know it can end up doing the wrong things. But the really good are those the throwaway ones, not good for the environment, but then at least you're not saying to someone, here's a charger. Yeah. Because oftentimes that's impractical, isn't it? But yeah.
And if you had a message for people who work in this setting, in homelessness settings, what would you say?
I would say thanks, because you're a miracle worker. But also, like I said before, but also perhaps, obviously don't judge anyone for smoking or using drugs or drinking, because that's perhaps the only thing that they can rely on. And they might be trying to quit anyway, but also perhaps introduce the idea that actually, like I've said before in the video, if we can get you off smoking, maybe it will make you feel better. I known for years that I can't sleep, I've done all this stuff. Well, actually, probably smoking doesn't really help. And so just really non-judgmental, but really concise, clear bits of information, like, try a vape for a little bit, and then the money that you do get from either benefits or from begging or what have you can spend on things maybe like food. Because I feel like at the time I wasn't interacting with services, I'd given up, and so it is really hard, but I think it's one less thing to worry about. So if you're sleeping rough or in a hostel or wherever you may be, that's stressful enough. But I'm a very addictive person, as you might imagine, and so then you got to worry about, have I got a cigarette for the morning? So it's just maybe just encourage people to think about that this isn't forever, and there's always hope. And obviously the first situation is not giving up smoking, it's getting somewhere to live in and getting out of trouble, but you will feel better. Yeah. But it's okay that you do it at the moment, but we'd like that not to be that's not in the image in the end. Just, I'm all about positivity, and I never thought I'd get out of it. And so to be vaping now, and not like a long-term thing, like you will get out of this, we're going to help you, hopefully. But think about how much more money you will have if you don't have to buy cigarettes. And also, I was very naive. I know one never expects to be homeless, but I never knew about street drugs and things like that. So when I did smoke these ends with, who knows what it was, I imagine it was Mamba or Spice or some such, but it sent me absolutely doolally, and I was really scared. So if someone had said, don't pick up, I tell people all the time, I'm like, don't get it out right, just don't pick out of there. So education for people, because you know, the homeless population is very varied, and yeah, and keep doing a great job, because I didn't always seem grateful to help. I could be quite rude to people, but I think once you get out of it, you look back and think, they probably did save my life.
Yes.
Yeah.
Yes. Yeah.
And now I wish that I'd I wouldn't wish that I'd done anything, but it would have been perhaps more helpful long term to know about, especially not picking up products. And also, if there was a vape, and I don't know how we feel collectively about vaping, I know it must have its drawbacks, but things like that jaw thing has been such a good help. I've seen people collecting them and using them, and so things like that. I know it's all involved in budgets, but it would be good, wouldn't it?
Well, there was a review today, a government review, that talked about exactly that, and you know, using vapes as a substitute for smoking is very much, you know, part of that. So, and you've anticipated my final question, which was about what you'd say to other service users. You've answered that. Anything else that you'd want to add to that?
No, just I'm really grateful to be on things like this, because I never thought I'd be in this position. So actually, I know it must seem like sometimes it's a thankless task, but you know, people do recover from drugs and alcohol. People do give up smoking, and I would say I don't know that much about recovery because I'm only 8 months in, but we talk a lot about like not giving up, and so I know this one day at a time sounds cliche, but someone maybe smoked for years, then quits, but then has a mental breakdown or picks up a cigarette. That's also not the end.
Yeah,
and
yeah.
so
It's about progress.
It's about progress. Yeah,
absolutely. Thank you, Robin.
You're very
much.
welcome.
And I really hope that you can stay with us so that you can join the panel at the end. That's brilliant. Okay. Is that okay, Hazel? I don't know how
Fantastic. No, you've absolutely hit the nail on the head. In fact, we're slightly ahead of schedule, which is unheard of in these webinars. Really, really fascinating to hear your story, Robin, and I'm pleased that you can stay on with us, as I'm sure that there'll be questions that people have for you as we get to that point. Right now, I'm delighted to invite Dr. Debbie Robson and Dr. Sharon Cox to join us. And they're going to talk about some research that they have been doing in homeless settings. So Sharon, are you kicking off?
Debbie is actually. She's controlling the slides. Yeah.
Oh, right. Well, Debbie, go on then, over to you, and then we will power into our Q&A session. So do keep adding questions into the chat. Thanks.
Okay. Good morning, everybody, and thanks again to Robin for sharing his story on the webinar and in the NCSCT film. So I'm Debbie Robson. I'm a senior lecturer in tobacco harm reduction at King's College London, and I'm joined by...
I'm Dr. Sharon Cox. I'm a senior research fellow in behavioural science and health at the Tobacco and Alcohol Research Group at University College London.
And we're both really, really grateful to be part of NCSCT's training package. So we're just going to run through, kind of reinforce some of the things people have said already about the challenge of reducing smoking prevalence amongst people who experience homelessness, and also just give you a quick overview of some of our recent and ongoing research in this area. So as you've heard already, and you'll know from the people that you work with that most people who experience homelessness smoke or used to smoke. And And in a study that we did with colleagues at London South Bank University, we looked at all the literature that had been published across the world and found that up to 82% of people who experience homelessness smoke. And that compares to about 14% in the wider general population in the UK at the moment. And you'll also know that this group of people also smoke in a much risky way, so more heavily when they get the opportunity, and as Louise and Robin said before, share the same cigarettes with friends and strangers, and pick up other people's discarded cigarettes and remake new cigarettes from discarded cigarettes. And they also have other additional challenges on top of their tobacco dependence. So just under half also experience a mental health condition, and around a third also use alcohol or drugs. And many countries are working towards achieving a smoking prevalence of 5% or less in the next decade. And at 5% prevalence, there'll be fewer smokers in the world, but the 5% is still, you know, millions of smokers globally, and we've known for many years that 5% who will be left smoking it, they're likely to be people in lower and middle income countries, but they'll also include people in our mental health and substance use services and those who experience homelessness, which is why implementing the recommendations in the Khan review that's been published today is so important. So particularly around making smoking a key part of mental health treatment, and also the recommendation that accommodation for people who experience homelessness should be smoke-free. Because we can no longer have this situation for people who experience homelessness and those in our mental health and substance use services, whereby the greater the health and social care needs of an individual, the lower their ability to change is perceived by workers in those services or society in general. And for too long, these groups need to stop smoking as being seen as less of a priority than other health behaviours. So that what follows then is a narrowing of opportunities to change. So we're just going to give you an overview of some recent research and then tell you about some ongoing research. So over to Sharon.
Thanks, Debbie. So in the review that Debbie spoke about, one of the key findings really was that I think we included something like 58 studies, and only at that time one study came from the UK. The overwhelming majority come from the US. Now the US is bigger, but you know, we do still have a problem with homelessness and health in the UK. So following on from that systematic review, we ran this survey of 237 people accessing homeless support services to find out what smoking rates were like, what their smoking habits were like, would they want to quit smoking, and if they did want to quit smoking, what would be the method that they would most want to use, and what had they used in the past. So this is just a real snapshot of a much larger survey, but basically the key findings were that 90% of the people that we interviewed shared the same cigarette with other people, which we call going tos. So that's not necessarily that's where, you know, you're smoking it down to half or even beneath and then sharing it with somebody. And we know from COVID that now, but you know, we should have known this before, or you know, more broadly, that is actually a really dangerous behavior for spreading infections. And this is a group of adults with really poor respiratory health already. So we don't want to make that worse. 15% said that they smoked discarded cigarettes, and Robin earlier highlighted the dangers of that, and all of those are really, you know, crucial points. 75% they wanted to quit smoking at some point in the future, and that was really important because that's what we hear from the general population of smokers. In fact, it's slightly above. So this, you know, this myth that we have that, well, these people don't want to stop, it's not a priority for them, that just wasn't borne out in this survey. I'm ever so sorry, my home phone is ringing in the background. 9% though had tried to stop smoking in the month before the survey. Okay, so while there was this high desire, quit attempts were really, really low. And not shown here, we also found that quit attempts were brief and usually lasted less than 24 hours. We asked people what they would like to use in the future, and we gave them a list, and 77% were interested in using an e-cigarette in a future quit attempt, and some people had experience of using them in the past. But we asked what the barriers were to using different methods, and overwhelmingly they said that they couldn't afford a startup e-cigarette pack. Now, a startup pack is about £25 to £30, and if you're in universal credit, which is around £100, that's a lot of your income. If you're on no income, that's even more money to find for a product you're not sure if you're going to like, you're not sure where you're going to get it, and as other people have stated, you're not sure if you're going to be able to charge. Thanks, Debbie. So this fed into a feasibility study that that myself and Lynn Dawkins ran. Lynn was the PI for this project. I was the trial manager, and it was funded by the National Institute of Health Research. And a feasibility study, for those that don't know, is not to test effectiveness, but it's to test whether you could do a larger clinical trial. So we ran this 4-centre study, which was 3 centres in England and 1 centre in Scotland. 2 centres offered e-cigarettes and 2 centres offered usual care. And usual care in this sense is a referral to the Stop Smoking service. So we wanted to know, would people take up the offer of an e-cigarette or usual care? Would they speak to the researchers? Would they come back? Would staff be able to accommodate their study? So again, it's not to test effectiveness, it's to test whether we could do a trial. So we gave out, in the e-cigarette condition, a starter pack for 4 weeks, a starter pack at baseline and 4 weeks worth of e-liquid, which was supplied weekly, and a help to vape leaflet, which was developed with vapors. And in the control arm, or the usual care arm, people were given some information of their local Stop Smoking service. Thank you. So 153 people were eligible to take part, and 80 people were recruited in 5 months. So that was good. So we could recruit people. So we knew if we went for a trial, we would be able to recruit. 42 people received the e-cigarette intervention, and 21% quit after 4 weeks. 32 people received the usual care intervention, and nobody quit after 4 weeks. 47 were still in the study 24 weeks later. So that's important, because we want to be able to know at 6 months whether people are smoking or not. And the longer the outcome, the more conservative our approach to the analysis. So it's better if we can follow people up. And people told us, you won't get people back after 6 months, but well, we did. And actually dropout was comparable to people who are not experiencing homelessness. Now, really important for those working in the field was that we didn't worsen people's feelings of depression. Their anxiety did not increase, and their audit, so their alcohol use disorder scores, did not change. In fact, they actually declined, whether people quit or not. Thanks, Debbie. So that was what we did up until the pandemic, and then the pandemic happened. So some of the research that we've done during the pandemic. So this was a study that I had going before the pandemic, but then continued into the pandemic. So it was a bit tricky. We aim to recruit 100 homeless services in the UK to take part in a cross-sectional survey of what they currently offer. And you'll see on this map here all of the geographical locations that we covered. Now, because of the pandemic, we really struggled with recruitment. We invited over 700 services and we got 99 responses. So we didn't quite get the 100, but I can't tell you how difficult it was to even get this many. But we feel confident that it is representative of the homeless sector in the UK. So what do they offer? So 11% had an on-site stop smoking service. So that's good. That's better than we thought, but it's still 11%. 35% said that they refer but have no links with the Stop Smoking service. And when we probed that a little bit more, they said, well, we do sort of refer, but we don't follow it up. So, that's to be taken not as necessarily a green light that there's these, routes in to the Stop Smoking service. 12% refer and have established links with the Stop Smoking service, but again, said that they don't always follow them up. And only 1% had any established links with vape shops, which is important given what everybody said earlier about the fact that e-cigarettes do seem to be a preferred method of cessation for this population. Next slide. So this has just been published, this paper. Now, the issues caused by smoking, some of people have, you know, picked up on this already, but some of the things that really needed improving, and we touch on this in the NCSCT training module as well, but 62% of respondents reported staff smoke with service users, and as was highlighted in the video that was shown, you know, staff recognise this as a problem, but it's so ingrained in the service that people wasn't really sure how to start to retract that behaviour. 77% said cigarette litter was actually their biggest issue with regards to smoking in the environment. They had complaints from neighbours, etc. So, you know, we want to make these places, you know, as inviting as possible. So, you know, cigarette litter, it's unsightly, it smells. So that was something that staff had noted that was a problem for them. And half of the respondents reported disagreements between staff and service users about where they could smoke. But we did find overwhelmingly in the survey that people said that there was a willingness to do things differently, but they just didn't have the resources. So this VBA Plus module that is coming out today is absolutely on the money for that. It's really responding to something that people are asking for. Debbie.
Thank you. So as Louise and Michelle have already mentioned, so this is work still during the pandemic. So as everyone knows, in March 2020, the Everyone In initiative was launched to provide temporary accommodation for people who sleep rough, and about 5,000 people were accommodated in hotels in London. And there was a homeless drug and alcohol service across London rapidly set up. And from the very outset, tobacco harm reduction was part of that drug and alcohol support. And so what we did was we supplied the London hotels, and there's a couple of London hotels still open that provide accommodation for people who sleep rough. We supplied them with e-cigarette starter kits and refills for the duration of their hotel stay, as well as nicotine mouth pouches and RT. What we were aiming to do, I mean, it was great if people stopped smoking, but what we were trying to do is some harm minimization. So trying to prevent people congregating outside hotels to smoke at the height of the pandemic when everyone was in lockdown, and preventing sharing of cigarettes or discarded cigarettes, and also trying to ease people's discomfort or prevent withdrawal symptoms when they were confined to the bedrooms, and reduce the risk of fires, but also, as Michelle mentioned, the risk of eviction from hotels because of smoking in bedrooms. And we did some evaluation work, and particularly asking the hotel residents what tobacco harm reduction outcomes mattered most to them with this initiative. And it was largely, it wasn't necessarily about quitting smoking. It was, and Louise mentioned this, just not having the shame and the indignity of smoking other people's discarded cigarettes. So this one chap, a chap from Italy who'd been sleeping rough for 8 years and no recourse to public funds for that 8 years, said, you know, he just didn't need to worry about when it rained anymore because you couldn't get discarded cigarettes from the streets when it rained. And another chap who'd been sleeping rough in a market, he talked a lot about the embarrassment and shame he felt from smoking discarded cigarettes, and that just didn't happen anymore because of the e-cigarettes. And for the staff who were working in the hotels at the moment, what mattered to them most was that their clients just weren't stigmatized anymore because of their smoking behaviors. And something that one of the hotel staff said to me that still resonates today, and we did these interviews in 2020, was that the smoking of discarded cigarettes tends to often get used to discriminate people when all that person's trying to do is manage a fairly difficult addiction without any money. That's the reality. And he said, do you really think someone actively wants to be doing that? They're doing it because they really, really want a cigarette and they don't have any money. And in his particular hotel, about 10 people had remained consistently using the cigarette, the vapes, and had stopped smoking. And he said that, you know, those numbers don't feel like a huge deal, but, you know, this is massive in it, and it should be celebrated. In terms of what Sharon and I and colleagues at London South Bank University are doing now, so one of the things we're working on at the moment, it's an MRC funded study to develop a co-design tobacco harm reduction toolkit for use in the homeless sector. And what we've been doing is running some focus groups with staff and service users in homeless services. And our next stage is to do some co-design workshops to develop the toolkit and then pilot it in one service. And what we think the toolkit will look like at the moment, given our conversations we've had with staff and service users, is we'll have some templates of what a compassionate smoke-free policy looks like, some conversation guides about how you raise the issue of smoking without increasing resistance, some guidance on evidence-based treatments and problem-solving tips, and some actual samples of NRT and e-cigarettes, and some service user testimonials and tips. People on the call, on the webinar, can still get involved in this research if you want to. Anybody who works with people in the homeless sector, there's still an opportunity for us to run some online discussion groups to understand people's experience of good and not so good tobacco harm reduction in the homeless sector and what people want to see in the toolkit. And Ash will be supporting the dissemination of this toolkit. And I'll hand you back over to Sharon for the final piece of research that we're involved in at the moment.
Thank you. So following on from the feasibility study that could a larger trial work, we were fortunate enough to receive the funding for this fuller trial. So myself and Professor Lynn Dawkins from London South Bank University, along with colleagues from all of the universities listed on this slide, are running this 32 centre cluster randomised controlled trial. So an overview of the study is that we are each cluster, so each centre basically will be randomised. That's different to on a one-to-one basis, people being randomised to either offering an e-cigarette starter kit or usual care, which is currently the gold standard support. So it would be brief advice and signposting them to a local stop smoking service where they would receive nicotine replacement therapies and or behavioural support, but usually both together. And in this study, we are looking to measure how many people stop smoking at 4, 12 and 24 weeks later after being referred or given their product, how many people reduce their smoking, and how many people change their risky smoking practices. We're also running a cost effectiveness evaluation. So very well if things are effective, but they also have to be cost effective if they're going to be implemented in the long term. So that's part of this trial. And we're also running a process evaluation, which has a qualitative component to understand people's, when I say people, I mean people who are participants and staff, what is their experience of the intervention been? And also some stakeholder workshops will be run at the end of the trial to speak to key stakeholders, those people that would implement this, to find out what may be, you know, their experience or their perceived barriers would be to implementing this on a much wider scale. So if you're a service that would like to get involved in this, a homeless service, we do have areas that we're covering. So London and the South East, the East of England, Scotland, Wales and the Southwest of England. What does the study involve? Well, you have to agree to be randomised. You have to agree that the researchers will come along to your centre and train staff for a few hours, and that we will lurk around and come back. So basically, we will be there to help recruit participants. I mean, the staff, we need staff to recruit the participants, but we will be there. We will be present. Participants have to agree to give us their baseline data to be assigned to either arm. and that we come back and collect the data, and staff also have to agree to provide either the referral to the Stop Smoking service or provide the e-cigarette starter pack and the liquid on a weekly basis for 4 weeks. So if you're interested in this and you're in the areas where I said, sorry if you're not, but that's the way trials go, unfortunately. They're very strict. If you can contact Dr. Kirsty Saw, who's our trial manager, and here's her email address here, sawk@lsbu.ac.uk. But you can also contact myself or Debbie. We're part of this trial. Thank you. Oh, brilliant. Debbie, do you want? Oh, I don't think we've got time for the summary.
No,
it's all there, and everybody said it.
I've let you run wildly over, but never mind.
Sorry.
Yeah. I invite everybody to turn their cameras back on, our previous speakers. Just while we're doing that, did I hear you right, Debbie and Sharon, that so 11% of those that you surveyed had a relationship with Stop Smoking services? Is that right? Yeah.
Yeah.
So it's pretty low. So if you're a homelessness service listening to this, what would you say, and I'll probably open this up to Louise and Michelle as well, you know, what would you say that you could do to do something about that, addressing that, you know, that relationship? But also, if we've got local authorities and Stop Smoking services on here, you know, what would be your advice to them as well?
I guess it's a two-way street, that the kind of it's kind of the responsibility with both partners, really. So it shouldn't be just on the homeless services to reach out to the local Stop Smoking service, but kind of the other way around. But someone's got to take the first step and do the initial approaching.
And I guess many services, homelessness services, will have existing relationships with their local authorities, and it shouldn't be too far a leap to then find the right people to be talking to about smoking cessation, you know, with as part of that. Louise, you've got your hand up.
Yes, I think that the cuts have had quite an impact here. That what we used to do in Leicester in terms of outreach was very easy at the time, because we got enough staff to do that. We've got the flexibility, and now it's almost impossible to find enough boots on the ground, if you like, to actually go out to do that outreach service, and to do it so slowly. You know, services generally will be focused on the 4-week quit, and you know, people have to be ready to do that. So possibly with the extra money that the Calm Review has talked about today, you know, some of these more innovative and you know, outreachy sort of projects could happen.
Well, I mean, it's obviously only a recommendation in the Calm Review today. So all of you listening, get on Twitter, get to your local MP and tell them that we need this investment now, so that we can get on with doing some of this stuff and really helping the people that need it. Sharon, do you have additional thoughts? Yeah,
so I would suggest, so staff turnover in both the Stop Smoking services and the homeless centres can be quite high. So what I would say is that keep trying to make contact, waiting, because you just sometimes have to get the right person, and invite them in. I think that's key. Of this 11%, the feel that we got from the interviews was that somebody comes into the centre, whether that be, you know, once a month or once a week, somebody comes in rather than an established link where they're sending people out. And I think that's been key to a lot of the successful interventions. It's that you're not sending people to another appointment somewhere else. Just one other thing, somebody put in the chat, so addressing a sort of question here, when we say homeless people, who do we mean? Do we mean sofa surfers, rough sleepers? We are talking here, you know, we realise it's a community of people who are very different, and people's lived circumstances are also very different. And in which case, I would say that, you know, the sort of advice that you're going to be giving somebody and goal setting who is rough sleeping, compared to somebody who's, you know, maybe been in supported accommodation for 2 years, is going to be different. Find out where people are going. One project I worked with, they were working with people who were in supported accommodation, and they were on other medication which they received daily from a pharmacy, and that pharmacy actually offered them Stop Smoking support and advice. So it's sometimes just about working out where people are already going and making the most of those opportunities.
Yeah, I think you make a really important point, Sharon, about understanding where people want to receive support. And it maybe it's within the homeless setting, but pharmacies, we've seen time and again, can provide really effective, when they have good relationships and qualified staff, they can absolutely play that role. And I'm sure there are other environments as well. And as you say, kind of identifying that's really important. Michelle, I'll bring you in, and then we should go to some of the questions in the chat.
I just kind of want to say, I think there's like kind of really brilliant about making relationships, and like kind of from a London perspective, I've just put in the chat a MEC link, which kind of has all of the details of all of the services across London. But I think there's also something above that, making sure that there's pathways. So kind of using the opportunities kind of at a senior level to make sure that this is kind of on an ICS kind of agenda, that these kind of our service users aren't kind of missing out when we're kind of looking at how we ensure that there are pathways in place. So I think there's quite a lot of work to be done kind of at a local authority level, at a service level, a local authority level, but there's also a regional level as well, and a sub-regional level to kind of start to bring kind of together people so that they can get all of their needs met in one location.
Thanks, Michelle. So we've got a few questions about the sort of role of NRT alongside vapes in the chat. So one about, whether that's something that would, whether people could or should use NRT alongside using e-cigarettes, and if people are using NRT, how we get, this particular population. It could be, I think this stems from the conversation we've just been having. It could be difficult for them to get access to GPs, etc., how we can get people access to sort of on prescription NRT products. So I don't know, Debbie, do you want to pick up the question around, whether people should be kind of dual using a NRT product and an e-cigarette?
Yeah, so I think, if I'm right, Louise, that's addressed in the course, isn't it? There is some information about using NRT alongside vapes, and certainly there's other resources on the NCSCT website that address that as well. So yeah, it's safe to do. What I would personally recommend is that you maximize the use of the vaping device. So make sure you've got a really good vaping device that is good at delivering nicotine, and get that bit right, and maybe supplement that with patches as well. So, but yeah, both would be okay.
And in terms of how we can best sort of connect people to getting those sorts of things on prescription, Louise, from your experience, what would you say about, given that local circumstances we know vary?
Yeah, it's very difficult to generalize, I think. There is usually some sort of inclusion healthcare hub in a city. Now that's, that might not be universal, and of course people living in more rural areas might find it more difficult. Obviously somebody who doesn't pay for their prescriptions will be able to get NRT prescribed for them, but certainly if there's a stop smoking service, they will, if the person is willing to attend appointments, they can get their NRT. Some people may choose to buy NRT from a pound shop, and it's much cheaper to do that than buy it from a high street pharmacy, for instance. That might be a way of doing it. I'm afraid that there is no general answer to this that's easy. I mean, Robin, what do you think that?
I would just like to say it's really encouraging, and I don't want to say but it's almost like I think you already know what you're expecting, don't you? Like if someone's homeless and they are street homeless and they turn up to a service perhaps to get food or immediate shelter when it's cold, if you give them vapes or NRT, they'll be more likely to use it. But if you'd asked me in my time outside to make another appointment with someone, and then I haven't got a charge, I don't know where I'm going to be next week, never mind in a month's time. I was also very anti-services, so in terms of getting feedback from me, I would have just told you to F off, and so that's the struggle that you'll find. And I'd obviously, in an ideal world, it would be amazing for me to, or for people that are still in that situation, to get as much help, and I know that's what you're all trying to do, but in terms of the study, I think you already know what you'll find. I don't know if it but yeah, certainly, like even I know that charging, well, I've got two things to say, because things like charging, it's difficult, but most homeless people, myself included, will have, for want of a better term, a shitty old Nokia phone that costs £10, and they will be able to charge it. So I think in terms of if someone wants to quit, they will, I'm sure. But I also think what you're doing is very, very helpful to people who literally have nothing. And they won't. Some people won't even be on benefits. There'll be a sub part of that cohort that you'll never reach because they are literally street homeless and they won't have anything to do with anyone. But yeah, it's definitely encouraging.
And I think what you say, Robin, it's about reducing the barriers that, the things that people have to jump over in order to be able to get that help.
Yeah.
And I just wanted to ask you a follow-up question. So there's a few comments in the chat around the role that staff play and the kind of stat around staff smoking with service users. How do you think what can staff be doing to kind of, how does it feel when a staff member might be having a cigarette with you?
Well,
is that a real problem? How can, what can we do to make sure that staff are kind of leading by example?
I can't speak for every homeless person, but like I said before, I will admit that I have been very manipulative in the past. And so if you find a staff member that smokes, you buddy up with them, and more than likely they'll give you a cigarette, which, to be fair, looking back, is very selfish for the service user because cigarettes are expensive. And so if more boundaries were in place, and I know everyone wants to help and it's really sweet, but actually these are my cigarettes, I'm not going to smoke around you, or you can't have one of my cigarettes, but here's a vape, or do you know what I mean? Like some alternative would be better, because there's also, looking back now with this wise head that I've apparently got, sometimes it's obviously very hard if smoking is a choice that you've made, but you work very hard trying to help people, you end up giving, I do it here sometimes, I used to do it, you end up giving half a packet of cigarettes away, and that's an hour's wage, and so it doesn't really work. So I think because you want, it's nice to create this where we're all in this together kind of thing, but obviously it's probably not good for anyone if the staff is smoking with the service user. But then I imagine there's times when they think, oh, if this is going to stop them going wild again, I'll just give him a bloody cigarette. So it's really hard. I don't know how you guys do it. Hats off.
Well, and I think there are parallels to be drawn with mental health settings as well. So if you go back not that far, we have nurses outside having cigarettes with patients potentially, certainly being very facilitative of that. I mean, Debbie, do you think there are lessons to be drawn from the experience of mental health settings for staff in particular?
Yeah, so locally in our mental health services, all the tobacco dependence treatment advisors also support staff to stop smoking. And some work we've done in our local drug and alcohol services, where we've supplied people with free vaping devices or nicotine replacement therapy. We also do the same. We give exactly the same vaping devices to staff as well, so that they're quitting at the same time as their clients. So they understand what their clients are going through with withdrawal symptoms, but they also understand the devices and flavors and nicotine strengths and things like that.
Fantastic. Okay, we are kind of approaching the end of this session, and I don't want to wish us to run over. So thank you to all of our speakers, and to OHID particularly for having kind of bankrolled this module. It will be coming out to you by email. I'm just looking at the information from Andy in the chat. So currently it's available to people in England, and potentially that will change in the future. But at the moment, if you are outside of England, we'll let you know when it's more widely available. We will be sending out the recording from today's event and the slides. Really keen to hear as well from people on the ground about how this is being taken forward. As Michelle was saying, this is, we're in the foothills of looking at how we can really better support this population, and we'll going to want to learn from each other and share that information. So I hope we can come back in the future and have some more case studies of, you know, how we've actually made this happen in homeless settings around the country, and kind of move this forward again in the non too distant future. So thank you to everybody. We will close there, and I'll allow you to get on with the rest of your day. Thanks everybody.
Bye. Bye.
Thanks, Hazel. Bye, everyone.
Thanks.